Ladies and gentlemen, good afternoon. Luis, by the way, WebMethods is still working there.
Oh my God.
You didn't do so bad job. Right, welcome to this afternoon session. Thanks for coming. My talk today is about eHealth, which is digitalization of healthcare. And I will give you an overview of the development of eHealth in Estonia. The system itself is up and running for 10 years already. Then give you some facts about the usage of the system, and finally look at the future, what would be next steps there. Once I have to do this in 20 minutes, then this obviously won't be in a very in-depth overview. My background is that I'm a medical doctor, I'm a radiologist. I'm still working in the hospital. But I was one of the designers and developers of eHealth system as well, among of some other guys who are sitting here in the audience. I was designing it, and now I'm also enjoying the fruits of the eHealth system, or sometimes shortcomings. I'm also an eHealth professor in Tallinn University of Technology. There we have a 2 years master's program about eHealth. It's an international program in English. We have students from 5 continents. We are missing only students from Antarctica. Anyone from Antarctica from here? No? No. Okay, then let's see the slides. So talking about eHealth in Estonia, obviously we can't talk this without knowing e-government system in Estonia. So eHealth is a part of e-government system. But healthcare itself, it's similar to the organization of healthcare is similar to Germany and UK. So we have primary healthcare physicians, like gatekeepers, and hospitals which are private entities. The share of healthcare in Estonia is only 6% of GDP, so it's quite low. That's why eHealth has its quite specific role to make service provision as efficient as possible. As I mentioned, the Estonian eHealth system is up and running since 2008. So we have 10 years experience now. It really covers the whole population, not only citizens, but all residents. From birth to death, it's based on the X-Road and other e-government infrastructure. And every single healthcare provider has to be connected with the system. So are you big, are you small, are you private or public, the institution to provide medical service has to be integrated with a central eHealth system. This slide is about history, so nothing happens overnight. We started designing around 2000, but then in 2004 we got financing decision. We got some funds from EU, and this boosted development of the system. So we started with electronic health record, digital images, digital prescription, and digital registration. And by the way, if you look below these 4 services, then today digital registration is not working. So we can't say that everything has implemented as planned. However, other free services or domains are working very well. Which is nice is that once we are using the same system, then yearly there are coming new services for the patient, for the healthcare provider, or for administrative people. And if you look the history, then as in any country, the digitalization of healthcare starts from the healthcare provider level. So it takes time once hospitals and GPs get their computers, and this was the decade between 90 and 2000 in Estonia. The first real digital service was electronic transfer of reimbursement claims, so it wasn't actually medical service, but it was administrative service. And in 2005, all reimbursement had to be in electronic mode already, which meant that each healthcare provider which had contract with insurance, and which is obviously mandatory thing to provide services here, then they had to have at least this level of digitalization that they could make their bookkeeping and statistics in hospital. And then 2008, when health information system was implemented, then also medical data and medical services started to boost. So you see, everything takes time. I personally am consulting today around maybe 10, 15 countries, and I think this is very important to understand that even a country like Estonia didn't do this in few years. You have to make a strategy, plan, architecture. It takes time. Obviously, today it's not anymore 10 years, but few years. But you have to appreciate that large-scale socioeconomic systems should be very well planned. So we have we have done some research or investigation about our system, and we have listed here 7 success factors, what we think what are important. Financing, clear governance, legal clarity, mature ecosystem. You see, technology comes only after these regulatory and legal things. Then established online identification methods. So we pay a lot of attention on the security. No one is allowed to access to eHealth system without having 2-level identification, either ID card or mobile ID. Then access rights and standardization. So these are 7 success factors, and on the next few slides I will address some of them. So governance, we decided to have one single entity which is responsible for healthcare digitalization, and this was called eHealth Foundation. Today this institution is renamed and under the Ministry of Social Affairs. But at the beginning, it was very important to have around the table all stakeholders. As you see, there were main hospitals, Society of Hospitals, then Society of GPs, Ministry of Social Affairs, and so on. I was also a board member there, and every stakeholder has their own incentive, but if you have one single organization which is responsible to implement, we had to agree about the phasing of the project and priorities. We didn't include enough patients those times. This was a mistake. This is definitely something I would recommend to include. And medical doctors were against. So Association of Medical Doctors was against to connect hospitals, and they pretty much against nowadays also. And this is a very universal thing all over the world. Doctors don't like that their files are shared with others. This is the architecture of Estonian health information system, and this follows pretty much the Estonian e-government architecture. So data has to stay where it is generated, and then the access is given to entitled persons or institutions. So on the lower right corner, you see these three main databases where medical data are stored. So this is Nationwide Health Information System, Prescription Center, and PACS, Picture Archiving and Communication System. This architecture allows to implement specific services. For instance, we have a drug-drug interaction database available for a whole country. This is a very typical service on the hospital level, where you have one database. So this is a software which gives alerts in case you prescribe something what is contraindicated to the patient. But with this one central system, you can apply this decision support system for the whole country. So it doesn't matter, are you primary healthcare practitioner in the countryside, or are you in the large hospital in the city. You see all possible contraindications of this particular patient. This also allows some inter-sectoral services. For instance, here is an example of a driver's license health certificate application. So a person can apply through the authority which issues driver's license, and do this electronically, opening patient portal, applying for a health certificate, and if there are any contraindications, then the authority, road authority, gets just a notice that this person is healthy enough to drive. If there are problems, then the answer is that there is no certificate, not saying, of course, anything about the health. So what we have there in the central health information system, specific data, we have agreed that centrally we collect certain standardized documents. Then there are services like ePrescription, e-referral, e-ambulance, drug-drug interaction service, about what we discussed already, and digital images, and then cross-sectoral services. And having data in a health information system, this allows to create new services continuously. Short example about the patient portal. So every single resident of Estonia has their health account, and they have access through the X-Road to their own health account using either ID card or mobile ID. You enter your phone number, you get the code, and if you're allowed to enter, then this is how it looks like. So in the blue background, you can see your medical data, and then around you see your insurance, your underage children also, which is very interesting and popular service. price of your treatment, how much insurance had paid about your treatment. And also, which is very important, is that every patient or every person sees log files. So every person sees who, when, which doctor has accessed their data. So this is the medical content of patient portal. These green buttons are buttons to give or take off access rights. So you can document, by document, you can opt out from the system, and these are the files. This is log, screenshot of log files. So this is my personal health data account. So every log what I have done is seen there. Legal environment is also very, very important, and we discussed a lot before implementation of the system, should we have separate law for the eHealth, but finally the decision was that we incorporated eHealth things into the Health Service Organization Act. Because eHealth is just a part of healthcare, or it's digitalization of healthcare. All healthcare providers must send data to the central system. This gives data integrity, access only to licensed medical professionals and the patient has right to close the data. We use opt-out concept. There is an ethical committee, and also we say that the citizen or resident or person has the control over their medical data, so citizen can declare intentions and preferences, monitor logs, and also opt out. This slide is about architecture. It's using the same concept as Estonian government system, as we discussed. Opt-out, use only of standardized documents. We are using HL7 CDAs. We should move from HL7 CDA to FHIR now, if this is something what you're aware of. But we obviously, after 10 years of usage, we have to move to the next level of data exchange standards. So what has happened during 10 years? As I said, really all citizens are there. All healthcare providers should be connected. These are the numbers. As you see, we have 1.3 million inhabitants, but there are documents about 1.6 million persons. This is because during 10 years, many people have passed away and many people have born. That's why the number is bigger. This is actually my favorite slide. The red curves shows the use of the central system by the healthcare professionals. So you see, first 2 years, very low uptake of the usage. Of course, politicians asked us that, well, you have spent European money, no one is using it, you are absolutely useless. But fortunately, there was there was enough braveness to keep the system alive, and now you see there are 2 million queries a month done by the healthcare professionals from the central system. This is additionally to electronic medical record what is used by the physicians. So these are the queries from hospital to, let's say, from the GP practice, or query from the GP practice to the hospital to see where else the patient has been. But what is the most interesting thing is the blue curve, and this is the patient or citizen. So you see people are looking through their patient portal the data as much as, almost as much as physicians. And this is really rewarding, I think. This shows that people care. about the health data. The green curve is about the number of the documents sent to the central system. This is about ePrescription. So in Estonia, we don't have paper prescriptions anymore. We have only electronic prescriptions. And on the right side, you see the expenditure of for paper templates, prescription templates. So it's really almost zero. Yeah, and then very quickly, this has been one of the killer services in eHealth system. Really, everyone likes ePrescription. Patients like it, physicians like it, and pharmacists like it. Everyone is enjoying. This is another interesting statistics on the left side, left upside. This is statistics about patient portal, and the red bars are ladies, and blue bars, they are men. And when we started, you see, in 2012 with patient portal, then it's not that ladies are so sick in Estonia, but these are ladies of childbearing age, and they were interested about their, health status or baby's health status. But in very few years already, men followed this activity, so now it's quite equal. So what future brings, and I'm really a bit critical here, because this is Estonian eHealth strategy for 2020, and this was approved by the Cabinet of Ministers on 2015. And what I see today is that during these 3 years or 4 years, out of around 20 goals and indicators, only 2 have been actually implemented. So Estonian eHealth speed is not anymore as we would like to. But what is in there in the strategy and vision important is that we would like now to look even more from the person's perspective, and look not only from the person's perspective, but also from the perspective of different domains, not only health, but social and also labor information systems. 5 focus areas: data quality first, second is personalized medicine, third is comprehensive case management and cooperation of organizations. So as I mentioned, to integrate more domains, not only healthcare, to have really use of big data, to analyze data in more extent, and finally telemedicine or telehealth or eHealth for remote places. So these are the 5 areas for the future. And I will now proceed to the end of my talk, and I open one interesting initiative what comes actually from Finland, and this is about how to integrate person's data around the person. So, and the idea is to generate similar number for personal data as we have in banking for money. So it's similar like IBAN, International Bank Account Number. The same is IHAN, International Human Account Number. And the idea is really that the data is around the person, and you are the owner of the data. You can collect not only health data, different other personal data around your accounts. So this is something what we see is the future for the cross-border integration and so on. And why this is needed? Because if you look at the Estonian health information system, this is governmental system, and it's as you see, it's still slow. It's well implemented, but to create new service to the open market, this is not enough. We need consent mechanism, especially because of GDPR, and there are some other shortcomings what this IHAN could solve. Here is a list of a couple of new services. So what we need to add there are these yellow and blue boxes. So add consent engine and also open the marketplace. And this case we can use not only state-provided services, but open really market for other as well. So to sum up, well, these 10 years, this has been paradigm change from the healthcare provider side, because we as medical doctors, we still have thought as we are the owners of the data, but the case is opposite, that the person is the owner of the data, also health data. Gradual change of data usage from point to point to the shared. Change of workflows, distributed digital system should avoid malicious modifications, and we kind of using hash chain or blockchain, so everything is time-stamped. So thank you for your interest.
Thank you, Professor Ross. Okay, we do have a few questions here.
That's great.
There's a question here that was asked kind of a bit earlier on. We may have answered it, but let's talk a bit more about it. The question was, how are the information about patients managed? Is there a central registry or is it decentralized? Now, I think your talk and your information shows that it's decentralized. I believe you said, we keep the data at the source. Well, why do we keep it at the source?
This is very, very good and proper question, actually. The answer is that the data, let's say, the most integral data is where it is generated. So it's either in a hospital or in the GP practice. However, here we have, let's say, break rules a bit concerning central system. So there are agreed 17 standardized documents what are collected about the person in the central system. This is one. Second central database is prescription center, where all prescriptions are. And third is medical images. So we have 3 central database, and the patient directory actually is patient ID. So all
several keys.
All medical documents are linked with personal ID. This is very important, because otherwise you have to use some, it's called master patient index, to link, some address, name, surname, whatsoever, telephone number. So using one single unique identifier is very, very strong tool, I would say.
Okay. Let's switch it around a little bit. Next one. You mentioned that you shared at least a personal disappointment that the 2020 strategy has not moved as quickly as you would like. Can you elaborate on some of the factors, political, financial, the next steps just much harder? We've seen that already a lot. The next steps are harder in many systems.
Well, this is something what said in Russian, that "не мешай двигатель работать," which, if I translate it, that let engine to work.
Okay.
So it works. And to change it, for instance, to go on the next standardization level, it needs really bold decision, and it needs, again, to go through these success factors. You need money, you need clear governance, you need someone who says that, well, because politically, if something is working, it's hard to say that, let's make it better, because you don't know what will happen. Then you should be sure about the new standard, is it good or not, enough mature, and so on. So there are several factors. But on the other hand, Estonia is becoming to be a boring Nordic country.
Boring's not so bad. If we're healthy and educated but boring, it's not the worst place in the world to be. A question that we've all got to ask. Everybody always wants to know. You mentioned the magical word blockchain. How is blockchain being used in the eHealth solution?
Well, every document or data set, what is approved by the physician or nurse, depending who is entering it, gets a timestamp. So you can't change anything after you have approved your entered data. For instance, if I, as radiologist, I report right knee, but the image was about left knee, I have to make a new report. Okay. Because legally, you can't change your approved things. And once it's time-stamped, which is hash chain, a little bit different thing than blockchain, but basically time-stamped document, then this is the way.
Okay, so there's some systems just to ensure integrity based off a timestamp. It's not a full blockchain solution or something like this. No. Just small little bits to help secure individual elements. This makes sense. There was a small part in the beginning, and this harks back to 10 years ago, that the Ministry of Health doesn't fund it, and it wasn't even in the top 3.
Very good that you got this point. So the point is that, and we have seen this worldwide, if you ask Minister of Health your 3 top priorities, then it's pediatrics, then it's HIV, maybe something, these kind of things. You never get, let's digitalize healthcare. Sure. So that's why you need to have sponsor from the other ministry.
Is that because it's a little bit easier politically in general, not picking on any one politician?
Because as doctor, I can always say, you guys, you see, people are ill, people are sick. Sure. We need money for treat them. Yeah. And you're coming with your IT stuff, forget it.
Okay, so we had to shift the focus around a little bit. Okay, this makes sense. Yeah, and sort of in the same way, talking about resistance, and okay, the Ministry of Health was a bit like, You also made the comment that doctors are typically against these sort of systems, but then in the very end, you also say, well, guys, we have to change our view that people own the data, not doctors. So is that a kind of an age-old thing built into doctors, that they felt that they not controlled it, but a little bit controlled it?
This is how doctors and nurses are trained. So we are owners of the data. We have to make decisions. But this is not the life anymore. People get data from other sources, and I personally even don't try to if I talk some person with chronic condition, that I'm more wise than he or she. Because the person lives with this chronic condition maybe 10, 20 years, knowing everything about his or her disease. So who am I to say that, well, do this or that? We should be equal partners there.
Okay. But you sort of threw in a comment which was sort of like, even today the doctors still think that with 10 years of success. Okay, you're just saying it takes a while for people to change their minds.
Right.
Look, we're all stubborn human beings in general, no matter what field that we're in. Fair enough.
Sorry, you need some good services like ePrescription. ePrescription was something, but when doctors saw this, this is really cool. So I don't need to issue some papers and calculate what is reimbursement rate or something. And then this was nice.
Okay, all right. So if you want to change an institution, change minds, to have that one key service that the doctors could be like, yeah, this is great. and then that's like the entryway, the gateway drug, to use a terrible comparison here.
For instance, there are countries where are no prescriptions in the world. There are no prescriptions. There are in several countries where you can buy any medication from the...
What countries are those? I want to go there.
Yeah, I will tell you. But you know, in these countries, this doesn't work.
Yeah.
This is not something what works there. So you have to be very country-specific in this regard.
Okay. We'll have a couple minutes. I got one more, then let's take it technical for our last question then, which is, so a person was asking, are you using the open NCP for cross-border communication? I believe they may be referencing Finland, or is X-Road connecting somehow with the Finnish X-Road? Like, I haven't heard myself of the open NCP protocol, but is that a thing?
Do you know the answer? I don't know.
No, I don't know the answer either. Okay, I thought you might know. Excellent, good. So there are certainly different standards and protocols for connecting countries' systems and cross, what am I trying to say, middlewares together.
Right. So sorry, I don't know this.
Sure. Cool. But is it, because isn't it that Finland is basically got a version of our X-Road?
Right.
So because they've kind of got a version of our X-Road, then somehow the two X-Roads are talking to each other on their X-Road protocol. You can see I'm very technical. All right, we're going to wrap it up there. Thank you, Professor Ross. I've got a bag for you. One more round of applause for Professor Peter Ross.
Thank you very much.
Here you are, sir. I've got a bag for you.
Thanks. Thanks, Luis.